Hi, everyone. We have made it to our final Parkinson's Awareness Month webinar. So thank you for joining us every Friday for the past 5 Fridays. And I'm glad you were still able to make the new time. So I apologize for it being a little bit later. But I was actually just on an expert consensus panel to come up with treatment guidelines for on-demand therapy. So it is something that will benefit you all in the long run to coming up with the different practice guidelines that we have. And it was a great morning, and I learned a lot from my colleagues around the world. So today, I have with me Dr. Adam Sarkar, and which you have met in prior webinar sessions, not just from Parkinson's Awareness Month, but also from what we did this month, a couple of weeks ago, where he and Dr. Zamir did a discussion on the surgical interventions for Parkinson's disease. So we run the show of the movement disorder program. I do the medical part of things, and Dr. Sarkar does the surgical part of things at GNI. And we're gonna just take your questions. So while this is a webinar format, so you're not on screen, what you can still do is either use the chat function or the Q&A function to type in your questions, but some of you also sent some questions to us beforehand, and we'll get started with those. Since we are starting a little bit later today, it won't be a full hour, it'll be about 45 minutes. But if there's any questions that we don't get a chance to get to or to answer, we can answer those in writing and send those out via an email, the same way that you all got emails about these different seminars and sessions. And also, if you were unable to stay for the whole thing or missed one of the prior webinars that we did, all of the links for the prior webinars are available in the email that we'll send out following today's session. So you can click on any of them to revisit some of the information and hopefully get the information that you need so that you feel better about how we're all managing your Parkinson's. So let's get started. Hi, Adam.
Hey, Jill.
So we have 80 people signed up for this, and we have about 30 people on, so people will still trickle in. You guys have been wonderful in your attendance. And the first question we have is a DBS question. So are you required to take antibiotics after a DBS procedure?
So that's a generic question for any type of surgical procedure. Typically, we give antibiotics in what's called the perioperative period, at least for the first 24 hours. And with DBS, a little bit more pressingly, because there are devices that are placed in either the brain or underneath the skin in the chest area, we want to just give a little bit extra, maybe 3 days worth of antibiotics after each procedure. If you're really opposed to taking antibiotics, I'm not necessarily adamant about you having to do it, but one of the complications that does happen with any type of surgery, and DBS, of course, is infection. And so I think it's a small price to pay to take antibiotics to try to mitigate any kind of infection.
Sure. And the other part of that question was borrowing from, pacemaker practice. Do you need to take antibiotics after DBS if you're going to go to the dentist or have any dental procedures?
Yeah, and while it's true that when they work on your teeth, they can express bacteriological loads, but we don't do that for any type of neurosurgical procedures in general, not for spine surgery that I do, not for DBS surgery, not for brain surgeries that have cranial plates. So I think once you get it in place, you can consider it yours, and you don't have to think otherwise.
And that's exactly, I agree. I've never had patients that have needed dental work that have had a DBS implant come to me with a request from the dentist for any sort of clearance or need for antibiotics. So not the same as for sometimes what you hear with the pacer world. So another question about DBS. I learned that DBS can damage your use of your voice. Is this true?
So I think that that's a nuanced question. So there are procedures in the past that we used to do, and you know them very well, Jill. And actually, I would take this time to highlight the fact that DBS is remarkable for a lot of different reasons, but for certain one particular reason. In the past, if you had a tremor, it's likely you had tremor on both sides. The procedures that we were using at that time as neurosurgeons, maybe 50 years ago, were literally only able to address the tremor on one side. And so you would have this horrible tremor on one side because you get a lesion. That's what we used to do. And then you'd have this, so you'd fix one side, but you couldn't fix the other because we found out that if we did these bilateral surgeries, there were speech problems or that could occur. It's true that there are situations where language or speech phonation can become affected, but equally, and I'm sure you found this, you can learn how to program around that. And sometimes patients will have two dominant settings. One that's really, really important for when they're, say, fine motor control or doing things, and another for when maybe their fine motor control is not the best, but their phonation and their ability to speak is far more clear. So I would say that that's what I would tell you.
I would agree. And what I would also say is we know speech and voice is a problem with Parkinson's,
Mhm.
whether or not you have DBS.
Yeah.
So the question is, can DBS maybe exacerbate a little bit of hypophonia or a little bit of dysarthria? Possibly the same way that medications can too. And the way that we mitigate medications is the same way we would approach any potential issue with DBS, with either changing the settings, programming on different contact leads, and things like that. It's not something that's unique to DBS, but it is absolutely something that we can manage the same way we would manage it in other aspects of Parkinson's, which
Absolutely.
means things like loud therapy or speak out or any type of vocal coaching and therapy is going to be just as much a part of your treatment strategies going forward with or without DBS.
And you know what, Jill, I think you just mentioned a couple other therapies, and I think that's really important for everyone to understand that we're really all in this as a continuum.
Mhm.
And I think there may have been a thought, say 15, 20 years ago, where it was, oh my gosh, now I'm so awful, I need surgery. I think surgery is creeping up more and more into the realm of patients thinking about having it while they're still quite functional. But surgery doesn't mean that everything else just goes by the wayside. It still means there's a lot of effort and a lot of participation on the part of the patients to do those big and loud therapies, to do those boxing therapies, to be very much engaged and still, as you probably tell your patients, DBS doesn't mean that it's a light switch, it turns on and now you're on. There is still going to be medication. DBS is a way with everything else to
Mhm.
try to optimize your health and really your just your day-to-day activities of daily living and your viability.
Absolutely. So we did get a question that came through the chat. Please discuss Parkinson's disease and moderate alcohol consumption, 2 to 3 ounces of vodka per day, only on Sinemet, venlafaxine, and Xanax. So while there is nothing that says that you can't enjoy a drink with Parkinson's disease, this is a neurodegenerative condition that can affect balance, and it can affect speech, and it can affect cognition. So we know that alcohol can affect balance, it can affect speech, and it can affect cognition. So you may be more susceptible to some of these side effects of alcohol, having had Parkinson's. But as I said, this is something that's more on an individual patient basis. So we would never say excessive alcohol intake is appropriate any place. But if you have a glass of wine with dinner or a martini with dinner or something like that, and you tolerate it okay, then it's fine. If you notice that you're a little bit more off balance afterwards, or you do feel like it takes longer for you to recover from a drink than it once did, then it may not be an appropriate thing to indulge in. Another question from the chat, like voice, can DBS affect vision? If so, is there a programming workaround for vision?
Yeah, so I would say this, and you may have seen this a couple of times, Jill. There are two different targets, at least for Parkinson's, and that's what we're talking about because this is Parkinson's Awareness Month. One target is in what's called the subthalamic nucleus, and we don't have to get too technical, and the other one is in the globus pallidus. Each of those targets, because the brain becomes so constrained and we're coming towards the center part of the brain, each of those targets can potentially come into play with what we call structures that are required for vision, like the optic apparatus. But at least in our practice, what you and I do, we have our patients awake at some point in time during their surgery, during their stimulation. And so if there ever were a problem, we could easily remediate that by changing where we place the electrode, because what your patients probably understand is that DBS is a piece of physical device that actually goes into the brain. And that time of surgery is the best time to change. And so you don't, as the programmer, Jill, need to do any workarounds. We want you to just focus on therapy, not side effects.
And that's the most optimal scenario, but I will tell you that there are times when we do have to do the workaround. And same way like it is for voice, it often is based on the location of where we're stimulating. So if someone comes to me from outside our institution and they are having some of the visual side effects, it usually means that what I need to do is stimulate on the more superior leads as opposed to the inferior leads. There's 4 contact points where we have the ability to stimulate. And if we can adjust where the main area of that stimulation is, we can sometimes have a workaround. Sometimes it's difficult, and it is something that we will try different groups for, or we will try different levels of stimulation, but we weigh whatever we're doing with the improvement of what they have gotten from DBS to begin with. So if moving the contact point therefore impacts their tremor, then we might have to find a happy medium instead of all or nothing in one or the other. So there are workarounds, but with anything, sometimes it takes a little bit of trial and error to get to it.
Yeah, you're right, Jill. I misunderstood the comment or the question. It really was for everyone with DBS. We tend to, well, not we tend to, but I do my patients awake, so we understand right there what is going to be their greatest impediment to therapeutic excellence. But you're right, there are some centers which try to assure patients that it's just as fine to be asleep during the surgery. We'll take care of everything, and then everything will be fixed on the back end, so to speak. I think that puts a lot of pressure on the patient's physiology, on your programming, and I think that's when we see frustrations in patients, and that's perhaps also some quote unquote failures of DBS, but I don't think it's a failure of the therapy, it's maybe a failure of execution.
Right. And then another question, not from here, but from before, if there is a side effect for whatever reason from DBS, is it possible to have it fixed? Can you revise it?
Well, so maybe that's two different things, Jill. If you mean revise, well, of course, deep brain stimulation is a series of components and devices that are electronic and plastic encased. And so, like anything, just like your car, your toaster, they won't last forever. They could wear down. There could be an infection, or I've even had this case where the target wasn't selected optimally, and we've taken out the components and replaced. So it can be replaced, but we would do that. I think both you and I would have a lot of debate, not against each other, but deliberation whether we can really further optimize something or not, because I always feel your first surgery is your best surgery and your best opportunity.
Right.
Your second one engenders a little bit more risk and maybe a little less benefit.
I would agree. So the short answer to that question is yes, anything can be revised. The optimally though, you do your best not to have that be an issue. And as a programmer, that's my part of this equation. We have a lot of options available to us to have multiple different strategies to kind of address what needs to be addressed. So even if things are not, say, optimally placed for whatever reason, there's still a lot of leeway that I can do with my programming strategies in order to make sure that we get a functional and a symptomatic improvement. It works best when things are absolutely everywhere where they need to be. So, but as for this question that came in, if there were issues and patients weren't feeling like it was being optimized, then making sure that you're seeing someone that knows all the different nuances of programming is the first step, because there is lots that we can do if just very simple programming isn't getting you the results that you need or that you had wanted. Some other questions that came in before. Can PD affect one's appetite, greater or less? So it can go both ways. And it's usually not the Parkinson's itself. So it's the medications. Medications for Parkinson's can cause nausea. So that might mean that you just don't feel like eating because you feel a little sick all the time. Medications for Parkinson's can stimulate appetite. So impulsivity and compulsivity, if you're someone that likes to nosh on chocolate or salty snacks, you might notice after you start medicines like ropinirole or Mirapex, Requip, Pramipexole, Nupro, things like that, even carbidopa, levodopa, these might kind of increase those impulsivity and compulsivity tendencies, and you might eat more. The other part of things is the cognitive part. So if somebody is starting to have signs or symptoms of Parkinson's disease dementia, it is not uncommon when cognition is impaired that appetite sort of wanes. There's lack of interest in it, a lack of desire to want to do it. You just don't feel hungry. So those are how it comes out. It's not specifically Parkinson's itself related. And then, do you know an exercise program that will really help with Parkinson's disease? I use the gym 3 to 4 times a week. So kudos to whoever sent this in for using the gym 3 to 4 times a week. That's wonderful. So you have already set yourself up for a good foundation. But there are specific therapies and exercise regimens for Parkinson's disease. I will say the caveat though is do what you like best. So don't just do the thing that's specific for Parkinson's because it's for Parkinson's if you're not going to enjoy it and then you're not going to do it. So if you're already going to the gym 3 to 4 times a week and you're working on things that help with balance, that help with strength training, cardio, you're getting the basics of what you need in. Now, if you're doing that and you're saying, I'm still shuffling my feet, or I still feel like my balance is not quite right, then you might not be challenging yourself enough in the type of exercises that you're doing, and then doing a physical therapy or a PD specific exercise program might be beneficial. Outside the therapy world, the exercise programs that are most common right now that people have been excited to participate in are the rock steady boxing classes. They're kickboxing specifically for Parkinson's. They do a lot of repetitive movements. They work on a lot of balance. And there's also a camaraderie of the people that attend the class. Now more are happening live. They had been predominantly virtually during the pandemic, but more are coming to open up to in-person activities. There's also dance for Parkinson's. There is also Tai Chi for Parkinson's, and they're not as, the dance for Parkinson's and the rock steady boxing are readily available to search if you look online. Stuff like Tai Chi for Parkinson's or for Pilates for Parkinson's are a little bit fewer and far between, but you can also find them if you look, or different Parkinson's advocacy groups can send out links or DVDs or whatever it might be for other things. In the rehab world, there's big therapy, which I'm sure many people on this webinar have already heard about. It's the complement to the loud therapy for speech, and you're able to participate in a very targeted, specific program that tries to retrain the brain, help movements feel less awkward and more natural, and help maintain balance and fluidity and things like that. And then the next type of therapy for Parkinson's is called Parkinson's Wellness Recovery, which was sort of born out of big. It's not quite as regimented as the big therapy. It's a little bit more of a cross between like a personal trainer and physical therapy, but all with the same endpoint of maintaining balance, maintaining fluidity, maintaining rhythm and things. So in answer to your question, yes, there are specific things. But if you're doing well at your 3 to 4 times a week at the gym and you don't necessarily feel like you need more or something's lacking, then keep doing what you're doing. As far as specific devices, their TheraCycle is a stationary bike that has been looked at for Parkinson's disease. You do not need to go and spend $10,000 on a TheraCycle. A regular stationary bike, if that is something that you're interested in, will suffice just fine. So we have some more questions that came in. Another DBS question. With DBS going to be available remotely, should an existing DBS patient consider second opinions, meaning DBS programming available remotely? So do you want me to take that or you want to take that?
I'll start because
Okay.
I would say that another thing that we happen to do in our ORs, Jill, and you know this because the industry representative also reports back to you what happens in the OR, is that we really run through a series of things that give you insight as to how to get programmed and at least take your first shot at programming. Not that you necessarily need it, but we could tell you, hey, Jill, we found unremitting paresthesias or things that were just annoying sensations or things like that. And we can tell you where that happened during what course of stimulation, or importantly as well, where we found a lot of benefit. I think it's a little bit challenging to take DBS a la carte, have a movement disorder specialist here, maybe your surgeon there, maybe another neurologist somewhere else. I think this is where you really just have to say that I like this team and this is the team that I have. That being said, I'm sure you could manage a patient. Like if we implanted a patient that came from somewhere else, you could probably manage them also remotely, but I'd leave that up to you.
Yeah, no, so one platform now, the St. Jude Abbott platform, is the only one that offers remote programming options. And again, I don't think that should be considered as the norm. It is a nice option to have, but mostly in the setting of things like right now, the pandemic, where people had been sequestered and some disruption in DBS programming had occurred because that's something that needed to be done in the office and face to face. But outside of a pandemic and outside of being someplace not like the dense area of the Northeast where you have access within an hour or so drive on the long end to where you need to be, it's an absolutely viable option and a great option to have. But I wouldn't pick the platform simply based on that fact alone. If you've already got a device in place, I would not say you need to have that removed and changed to allow for this remote option by any stretch of the imagination. If you're looking to have a DBS placed as a new DBS patient, then it's something that you can take into consideration based on your own personal geographic region and things like that. But it wouldn't be what makes or breaks my decision in going and picking a particular device over another. Oh, we got a recommendation for Parkinson's Place offers Zoom PD specific programs, getting back to the need for exercise and rehab. So thank you very much for posting that. Okay, let's see. Any new breakthroughs for Parkinson's disease? So I will say that the very first talk we did for Parkinson's Awareness Month was an entire hour on what's in the PD pipeline and what's been new for the development of Parkinson's disease. And since this was a question that came in beforehand, I put the link to that webinar in the chat. So if anybody wants it, they can copy and paste it to see. But the answer is yes. Not as what everybody wants quickly enough, but there are developments that are going on from new different types of on-demand medication therapies, a sublingual strip called Kinmobi, a medicine that helps extend the benefit of your carbidopa-levodopa by recycling it, called opicapone, which is the newer variant of entacapone, which some of you may be on. A newer mechanism that doesn't work on dopamine at all to help mostly with stiffness and slowness in Parkinson's, and that's a medication called Noriance. And then as far as what's not clinically available, but being looked at in research that are in the latter stages of research studies, phase 3 studies, so it means it's pretty close to what's coming out to clinical practice, there is a pump that's smaller than the current pump that's available for Parkinson's that doesn't require a procedure the way the current one does, which requires a peg to be placed. The new pump will be a subcutaneous pump that goes right under the skin, similar to older insulin pumps. So if anybody's thinking, oh, a subcutaneous pump under the skin that delivers medicine, and you picture the little egg that goes right on your arm or your leg or your abdomen for someone with type 1 diabetes, it's not anywhere near as compact as that. But it is still smaller than what it is now. It's about the size of a cell phone, about the thickness of about 2 cell phones, and it will deliver a liquid form of carbidopa levodopa just under the skin through a little butterfly needle and cannula. That's in phase 3 studies, so we're still looking at about maybe 2 years out before it's in practical clinical use. And then with the DBS devices, there are a whole host of changes that are coming to the different platforms. You just heard one where remote option programming is an option. There are others that are looking at directional leads, so you can be very targeted in where you want to focus your areas of stimulation, and again, to help mitigate any side effects that might come from DBS programming. And there is the changes in the software of the batteries that are allowing for almost sensing capabilities. So it's not quite sensing yet where it will register what the brain activity is and then adjust its stimulation itself. So it's not a closed loop, but what it is doing now is developing the ability to be able to record the brain's activity so that when I am programming, I'm able to look at that information to see when your tremors are most impactful and see if there's anything before that that kind of gives me a clue as to say, oh, there's some electrical activity that's changing in the brain. I should be programming to mitigate that sort of electrical activity so that we don't develop or the tremor doesn't break through itself. So it's getting very technical and it's getting very nuanced, which is a good thing because these are, while it might make my job a little bit harder, it does mean that you have better outcomes for patients going forward with not just medication management, but surgical management as well. So I encourage you to take a look.
But I think that's really a good point. I mean, we're getting to a point, and you picked up the term, and I'm not sure all the participants are going to understand it. We're getting to a point where we're going to try to take AI, artificial intelligence, and have it help with the programming, look for signatures of the brain and look for signatures, electrical signatures of Parkinson's, and try to understand, because the brain is a modulatable organ, and using electricity at the right time is ideal. And if there's a way of doing that more elegantly, I think that's where we're leading to. I do work and do these kind of operations in epilepsy patients, and we really have a beautiful system there. And I think Parkinson's will ultimately go that way. So you're right, Jill, it's getting more complex, but maybe even more automated to some extent too.
Yep. So 2 questions that came in through the chat. Are mindfulness and yoga helpful for Parkinson's disease patients? And the answer is yes. There are some studies to show kind of like a quantitative benefit, but it's really more just a quality of life benefit, because we know that anxiety and depression and pain are all things that are impactful in Parkinson's disease. But we also know that mindfulness and yoga can help these to varying degrees in patients with or without Parkinson's. So it's something that is, I would never discourage it. I would only encourage it. And I would also be honest when my patients ask me, I myself am terrible at yoga because I I breathe when I should be inhaling, and I exhale when I should be breathing in, and I find it very stressful for me. But I like stretching, and I like Pilates, and I like things like that. So it goes back to that idea of find the thing that works best for you. So if you don't have anything in mind, try everything, but it's not like it specifically has to be yoga or something else. And then we got a couple of questions that came to us beforehand, and this one now about supplements. So I get this question all the time. There is nothing specific for Parkinson's disease when it comes to supplements. In fact, studies on coenzyme Q10 that were done by the NIH were stopped because of no potential benefit. So while coenzyme Q10 can be helpful at 200 milligrams in the cardiac world, they looked at it from 200 milligrams up to 1200 milligrams in the Parkinson's world, and it didn't show any benefit or change. So if you're already taking it for your heart, great. If you're not taking it and you're curious, fine, 200 milligrams is okay, but it's not like you need to be on a higher dose or start it specifically for Parkinson's disease. B12 is just a good overall general neuro vitamin. So again, it's not that it's specific for Parkinson's. There's some data to suggest that Parkinson's and Cinemet use can impact B6 absorption. So sometimes a B6 neuropathy is a very, very, very rare side effect of being on Cinemet, but a B complex would get to whatever additional supplementation that you need. So B12, B6, B3 is just fine to take. There isn't a supplement that's specific for energy. That's the question we got beforehand. Unfortunately, I wish there was. My patients would be so much happier if I could give them something that I knew would give them a boost. So in lieu of that, I tell patients chocolate covered espresso beans are like taking a little vitamin and a little tastier, and that can sometimes be helpful for giving a little bit of a boost for energy. But the fatigue with Parkinson's is very real. So I'm not trying to make light of that, but it is something that unfortunately we don't have a specific supplement to take. And then over the counter things like I get asked about Restore Gold or Focus Factor or things like that. Again, there's no data to support them. It's not something that's necessarily harmful, but I would hate for you to forego other medical management in lieu of being able to afford like an $80 Restore Gold Factor vial of supplements. So that's kind of the long and the short of supplements in Parkinson's disease. Anything to add? Awesome.
No, I mean, I think you're right. Everyone is always looking for that magic pill. And I think if we had it, we'd all be using it for everything.
Yeah, it's true.
So no.
No. One thing to add to it, I get questions also about glutathione. Glutathione is not absorbable to cross the blood-brain barrier via the gut. So oral glutathione, if anyone is taking that or being suggested that they take it doesn't work. Intranasal glutathione, again, there have been some studies to look at it. It's neither here nor there. It's not harmful. It's not overly helpful, though anecdotally, some patients will say they feel like it helps them a lot. They feel like they get a better on with their medications and they want to use it, and that's just fine. IV glutathione, which is about $10,000 a pop, absolutely not. Please do not even entertain that thought. That has been shown to have no clinical evidence whatsoever, and is so outrageously expensive that it is absolutely not something that you should consider. Which gets to another question about why is Rytari so expensive? So there is a long-acting form of carbidopa-levodopa called Rytari. It's still branded, so there's no generic that's available for it. For those that are not on it, it is a capsule and not a pill. And if you were to break apart the capsule, it has little pellets inside that get absorbed at different rates, which is how it extends the duration of benefit for use. So the answer to why is it so expensive is because it's a branded form of carbidopa-levodopa that is so readily available and has been generic for forever. Insurance companies will not put it on their formulary as something that is a viable alternative. or they will not equate it with the same level. They will not put it in the same tier as carbidopa levodopa that's already available. So it might be part of your formulary, but it's a higher tier, which therefore makes it a more expensive medication. And that really is the reason as to why some insurance companies, it's covered better than others, but on the whole, it's a much more expensive medicine than generic carbidopa levodopa. If it works that much better for you than carbidopa levodopa does, you can appeal it, you can do all of that, but it doesn't necessarily mean that it will take the cost of the medication down. So we've actually gone through all of the questions that have, oh, there's one more question that came to us. The question is, what do you recommend for freezing of gait? Someone who's on Cinemet and then Azilect was added. And freezing of gait is extremely difficult to manage. It's not something that responds well to medication, as the person that submitted the question is experiencing. Honestly, the thing that helps with freezing of gait best is the different types of cueing strategies that are learned through physical therapy. So whether it's different marching in place strategies to get you going, whether it's a visual cue or an auditory cue or a tactile cue, touching your leg and you start with that leg, visual cue, having a laser light on the floor or something that propels you to take a step, or an auditory cue like a metronome or just some music that has a very syncopated rhythm that you can walk to. Those are the things that help with freezing of gait best, unfortunately. Medication is really very hit or miss, mostly miss. Is there a company coupon for Rytari? There is, but only if you have commercial insurance. If you have Medicare insurance, any federal insurance are not eligible for any of the coupons that any of the drug companies have. Now, there are patient assistance programs that can be available to everyone, things like RX Alliance, and another one that I am blanking on off the top of my head. But these are different types of programs that you can get vetted on based on income and the amount of medications that you take and the cost of all of your cumulative medications that you might be able to get patient assistance for. A lot of stomach-brain connection with regards to probiotics. Any thoughts? So probiotics can sometimes help with keeping the flora of the gut okay, so that it helps with absorption of meds, but it itself does not necessarily have an impact on the pathology of Parkinson's disease. Now, they are looking at, is there inclusions of alpha-synuclein and things like that that cause the Lewy bodies that have that cause the loss of dopamine in the brain? Can they be found in the gut sooner than they can be seen in the brain? There is, there's research that's looking into that as possible biomarkers, but it's not something that really impacts clinical use. It really, at this point, probiotics and medical management comes from the ability to help keep things moving steadily in the gut, so that food and medicines get to where they need to get absorbed, so that they can be utilized effectively. And any other questions before we wrap up? Because I think we're getting close to time. Okay, my husband takes Nurians and Kimobi and he barely falls anymore. Okay, that's great. So that indicates that his freezing of gait was really related to an off episode that he was experiencing. And so that's where, if you can see that your freezing of gait happens as your meds are wearing out of your system, then that is a different picture. I was thinking of freezing of gait regardless of when your meds were working or not. So if you have the meds in your system and you're still freezing, that's very difficult to treat. But if you have freezing that occurs when your doses aren't working or you're at the end of your dose, then that's a different story. And it can absolutely be managed by medications. That's the kind of gait issue that can potentially be helped by doing DBS, because you're extending that on-time effect of your medication. There you go. So let's see if anything else is coming through. So, well, I just wanted to say thank you to everybody who submitted questions, and thank you, Atom, for participating.
No, it's great that you coordinate this, Jill.
And oh, I thoroughly enjoy it. I enjoy my in-person programs even more, but this was a close substitute. So next year, hopefully, we'll have our nice big symposium on the river in Lambertville, and it'll be a little bit more back to normal. Oh, one last one that come in. What activities can or can't you do after DBS? I'll let you take that.
Really, there are none that would be prescriptive. So, for instance, right after surgery, you can't go scuba diving or something like that because we want your wounds to heal. Most patients are just happy to get their lives back. Some of my more active patients, maybe sportsmen that are hunters or things like that, and if there's a battery pack on their chests, they wonder about what will happen with a gun. We've done that. That hasn't been a problem. Some people like to skydive. That's not a problem. So I think that the only thing that you have to be a little bit careful about when you have this hardware on you is if you're in a very powerful magnetic field setting, but most of us aren't. So I think, not to be facetious, really the device, regardless of the manufacturer, is safe to engage in all your, or to become re-engaged in all your normal activities of daily living.
Yep, that is true. I counsel patients on the same thing. Now, there's always that few and far between, like who's a championship show, like horse rider or stuff like that. It's, you know, the more jarring or extreme the activity, the more we'll have a conversation. But for the usual things that most people do,
Yeah, 100%.
There's really nothing that is limited.
Yep.
So with that, I just want to say again, thank you for everybody for participating. You'll get a follow-up email with links to all of the webinars. And if you have any questions that pop up, feel free to respond to that email with the questions, and we'll happily get those answers out to you. And I hope you have found all of these helpful and informative. And I hope you enjoyed Parkinson's Awareness Month. So have a great weekend, everybody.
Bye-bye, everyone.
Bye-bye.
Thanks, Jill. Bye-bye.
Bye.